I am legitimately so excited to bring to you today one of my favorite alum to work with. She has been in this class, I think, maybe 3 times, 4 times over the past few years. Her story is amazing, it's inspirational, it's a phenomenal education on how your startup can grow, pivot, and evolve as you launch it. And she's gonna get into all that, so I won't steal her thunder. What I will tell you about her is that she is the co-CEO and co-founder of WorkIt Health, an Ann Arbor-based telemedicine company, where she leads business development and partnerships with their healthcare plans, clinical strategy, and driving outcomes research. She serves on the boards of several different economic development organizations, perhaps most relevant to y'all, Venture for America of Detroit, and then also U of M's Accelerate Blue Fund. Named Schwab Foundation Social Entrepreneur of the Year, Crane's Notable Detroit Woman in Health, and Ernst & Young Midwest Entrepreneur of the Year, featured in the Journal of American Medical Associations, Wired, The Economist, and New York Times. She's a social entrepreneur, a pioneer in the field of health informatics, a yoga teacher, a certified wilderness therapist. What? Who does that? She's got a BA in English Lit. What? She's got a master's in social work. And as if that wasn't enough, she's got a master's in information science. She's a 3-time U of M grad from 3 different schools on campus. I honestly don't know any other alum who's got that kind of diversity in their background. Without further ado, please help me welcome Lisa McLaughlin. Advance your slides right there. Okay.
Hey everyone, that was an embarrassing intro. We went across the map to my one yoga teacher training class that I taught before I stopped being a yoga teacher trainer. A lot of try, do, fail, different aspects of my life. But it's great to meet everyone. It's great to see you go blue, ×3 for me. So I love the fall in Ann Arbor. I love the spirit of entrepreneurship that's grown on this campus, and since I started my company in 2015, has just accelerated massively. So excited to see many of you go out there and build and basically get shit done out there, changing a lot of the big social problems that we have in the world. I'm gonna talk a little bit about my journey as a social entrepreneur. So my company, like every startup, has gone through a lot of 2 steps forward, 1 step back, 1 step forward, 3 steps back. Like everyone who takes the entrepreneurial quest, so to speak, I've had my highs and lows. So try. Really, I am someone who never imagined myself to be an entrepreneur. So I know your generation has grown up, you've seen Shark Tank, you've been surrounded by a lot of messaging and communications about entrepreneurship, but I grew up actually in Ann Arbor, raised by academics, and what you wanted to do growing up in Ann Arbor was be a professor. That was like making it in the world in Ann Arbor, in my world. So life happened, and I, as someone who just has a long history, genetic history in my family of substance use disorders, have always tackled life kind of from a candle burns at both ends kind of perspective. From the ages of 15 to 22, I had a really serious substance use disorder. I was a really successful undergrad at University of Michigan. I studied English. I went all over the world. I did a lot of cool things, but I really struggled with my mental health. I had serious anxiety use disorder, and I started drinking and using drugs in high school, and that really accelerated during my time on the Michigan campus. Eventually, fast forward, I got sober through a whole range of things that happened, and I started to have a phenomenal career. I went to graduate school at Michigan. I became a wilderness therapist. I studied social work. I did a lot of disaster response work that led me to complete crash and burnout of doing interpersonal practice in social work, and then I decided that I wanted to build systems, which led me to this crazy career in Silicon Valley, where I was working on really early ed tech products like Khan Academy and massive open online courses like Coursera to build open education resources. But I, at the time, was newly sober. I was surrounded in the Bay Area and everywhere I lived, really, by a lot of people still engaged in risky substance use. And I was lucky to be one of very few who actually got sober at the time that I got sober who have survived. So flash forward to why we're looking at this. In 2015, I was working in the Bay Area at a startup, working on ed tech initiatives, working like 90-hour weeks, and my friend Aja died. And she was someone who I had lived with in grad school after I got sober. She was studying to be a nurse practitioner. I was in information science school, was like really embracing sober life and studying computer science and UX design, and how that interacted with social work. And she passed away, and she was like maybe the 6th person I knew from the Detroit area recovery community to die, but she was very close to me, and I had a trailing Facebook message from her when she left the ER, and it was just devastating to me. And I had this like crisis purpose moment where I was like, if I'm gonna work this hard, and people I know that are this young and this amazing are dying, like I'm not gonna work this hard on ed tech. I love education, I love the University of Michigan, but this was the problem that I really cared about, that was killing people that I loved, that I still had family members who were still struggling. And by the time that I started WorkIt Health, Aja was maybe the 6th really close friend, but maybe the 50th person I knew that had died. And so really, I saw people dying from the time that I got sober in 2002, really start to accelerate in Detroit in 2004. And by the time the opioid crisis hit headlines in 2015, I really knew over like 60, 70 people that had died, mostly from around here. So, and these are people from all walks of life who had different kinds of backgrounds. Some of them were studying to be doctors and couldn't go to treatment because they didn't want to lose their license. Some of them were struggling from trauma, all sorts of things. But I had a best friend in the Bay Area who was my sponsee in recovery, Robin McIntosh, and she had a design thinking background. And she had built a bunch of front ends for me at the ed tech companies where I had worked, and she'd run her own design and dev firm right when Rock Health was starting, which was a big aggregator in San Francisco of early stage digital health companies. And we decided in a moment of whimsy, in a hacking session in her apartment in Oakland, to start a company together to try to tackle the opioid crisis. And really what we were thinking was we were at rock bottom. We were thinking substance use care has to get better. There's no reason why San Francisco's pumping out diabetes care platforms that are in your pocket, and in order to go to rehab, you still have to pay $30K, even though 1 in 3 Americans struggles with drinking over the course of their life. And we were seeing accelerating numbers of people dying from overdoses. So we decided to start a company. She left the company she was working on, which was a yoga startup with her fiance, where they were ready to kill each other. And she first was like, well, why don't we work on Yoga Buddy together? You're a yoga teacher. And I reminded her that I had taught 1 yoga class, and that's all I had done with my regular. Both of us hated yoga at the end of the day. And she was going to break up with her fiance if she kept going with Yoga Buddy. But she had the experience of pushing a startup all the way through, all of the training at Y Combinator, pitching a seed fund, getting funding, all the way through to acquisition to Yoga Journal, very much earlier stage acquisition, like EHour. But she kind of knew the early stage space. And so we started this company. The goal was to make sure our friends didn't die and make sure care kind of accelerated to the 21st century. So flash forward. In order to do that, we had to just make a lot of wild attempts at redesigning care. So what that looked like for us was first, we both had this design thinking IDEO background, getting a bunch of Post-its, throwing hundreds of them at the wall, saying why are we alive and our friends are dead? I have 20 years in recovery now. Robin has 16 or 17. But we tried to really map out where their journey broke down and ours didn't. So that gave us a lot of early user archetypes of exactly the sort of person who is mismatching with care. And that led us to this initial Get Help, Help Out app prototype that you see here that was a big disaster, right? It was we shipped it out to a bunch of people that we knew in AA who already had a recovery program that worked for them. And mostly recovery services at the time that we started the company were go to AA after going to $30,000 treatment in Florida or California, or bust, right? That was it. You joined AA whether you liked it or not, and that's kind of all there was to it. And that works for about maybe 5% of people that have an addiction. It's kind of the way CrossFit works, right? So if you love kettlebells, if you want to go to kettlebells, 90 kettlebell meetings in 90 days, like CrossFit works for you. AA is like that too. So it's like, go to 90 meetings in 90 days, get a sponsor who has a sponsor. It's a hardcore program. And some people, it works great for. It worked great for me. It worked great for alcohol. It doesn't work as well for people with opioid use disorder. So basically, Robin and I decided that we would really try to map out where AA was missing the mark and what else was needed to be offered so that people could recover. And this was really hard. Like, it looked like an MVP that was just an email chain that we started. We really believed in lean startup, and so a lot of it was just sending an email list of shares, like audio shares to friends and family that were only opened by our parents. So we had like 300 people on the listserv. Initially, it was like Mom and Dad were opening it, and then some random rural person in Canada who was LGBTQ and couldn't find recovery services in where they were, in this completely undemarcated part of Canada that doesn't even have a city name. So that's what we had as a user base. But that person in Canada had a very serious active opioid use disorder. And we, because we were very big advocates for human-centered design, we followed what their needs were, and they needed straight treatment, which led us to the product that we have today, which is a full-scale digital medicine rehab program that treats people that have very serious opioid use disorder in a harm reduction model where we meet them where they are and get them where they're trying to go. So it's no longer like force everybody onto the wagon, whether you like it or not, whether you're 20 years old, like I was when I got forced onto the wagon, and feel really jilted by the fact that you're not gonna have fun for the rest of your life, or you're someone who's about to die and has had massive overdoses. And so it was really difficult to build for those types of use cases. So what we did, which was crazy, was we built for the hardest. We built for the opioid use disorder member in Medicaid who had nowhere else to go. And we scaled a company to a series in 118 million, Series C, 19 states as of yesterday. Welcome, WorkIt Health, to Utah. And to thousands and thousands of members who have recovered just through this process of iteratively test, design, test and learn through human-centered design what people need and how to design it. Fail. I like to share this picture because in 2017, we were really hitting bottom with trying to get coverage for our platform from employers and testing different ways that we could get people to pay for rehab. People that are early in recovery or just about to try recovery don't want to pay for rehab. No one wants to pay for rehab. Someone's mom might want to pay, but at the end of the day, healthcare insurance companies should be paying for rehab because addiction is a use disorder. It's a chronic health condition. It's a chronic relapsing condition, but it should be treated like diabetes or any other chronic condition that people struggle with. And so we were struggling to get coverage, and we decided that in order to reach rural populations like our member Zero from Canada, we needed to buy an Airstream and just drive around the country and just try to deliver our app to people from an Airstream so that they would know about us in these rural communities. Well, no one in the state of Michigan would let us park this thing. Like, we went to Monroe County, they're like, not in my backyard. We went to Lenawee County, not in my backyard. So it was like this ridiculous investment we made with our Series A funding, where we spent like a good chunk of our funding on this machine. We had no idea how to like manage the front-to-end cycle of, for instance, the bathroom in the Airstream was a huge problem for our clinicians. So there were things we faced that just seem ludicrous and crazy, but that I miss that time period of just like, well, what's it gonna take? Where are the people? Well, they're up in Marquette. Well, let's go there. That's what made our company great. Just like following those instincts and caring enough about the problem we were building for that we would be willing to do crazy things to try to keep people from dying. That's not the company I'm running today. It's we have a chief medical officer, we have a chief financial officer, we have legal and all these much more formal, bureaucratic, very boring things. But we also have this foundation of design thinking that stayed with us and patience as designers. That's, I think, what's made our company super successful. In terms of where we are today, so I always like to say a little bit about being a woman founder. So we know that, of venture capital raised, maybe 2% goes to women founders, and the majority of that is a woman founder who also has a male founding counterpart. And so in the case of Robin and I, we're not only two women, but we're co-CEOs, which is deeply scandalous in the marketplace. And we've been very successful raising. And I think we've been successful because we've been like crazy persistent. Like we were so angry about our dead friends and family that like I pitched the seed round of WorkIt Health like 350 times versus like I'll talk to a friend who's a developer at Apple and he's like, I started my startup, I pitched like 4 VCs and they said no. He's like, I think I'm gonna fold it. I almost like spit the drink I was drinking when I was talking to him out of my mouth. I was like, what? You did what? You're gonna fold it? So, I mean, you have to work on something that you care about so much that you're like, next person, like you find your backer, right? And that's why we were successful. I think in terms of how we've raised a community, I think our best employees are people that have been touched by this in some way. So really getting a community and culture around you of people who really care about the problem you're trying to solve makes a huge difference, because other people in recovery or who are struggling to get into recovery will like work a lot harder on anything, like a focus group in dev and design, an engineering prototype. Like we just had a blog up this week from one of our Agile Scrum managers, and he's in early recovery from alcohol use disorder, and he just designs differently. He builds differently because he has that experience. And now we have a lot of people with all kinds of backgrounds at WorkIt that aren't all in recovery, but having that built-in member design sensitivity, I think sets us apart from a lot of our competitors who are either background in private equity or, they're just doing it for the money. They're like, oh, a lot of people have an opioid addiction. Got to get in there, raise some VC, it's a hot topic, right? It's very much another differentiation of WorkIt has been science. So we built translational research into our care model so that everything that we're doing measurement-based care, which allows us to improve care. So we'll always have cohorts going, A/B tests of different protocols for medications for alcohol or opioid use disorder. We now have chatbots that helped predict within the product whether someone's going to need a clinical outreach or whether it's an admin outreach, and they're starting to do more natural language processing to just understand and work through ways to optimize our technology so that we can serve Medicaid, which you make in the average state maybe an average of maximum $250 a month for bundled care for opioid use disorder in our system, in our healthcare system in the United States and Medicaid. That's only possible with technology, with the engineering skills that you're all developing, to build something scalable enough, lightweight enough, that you can actually deliver it cheaply and use robots and the best care scaled to reach those people. And that's been the challenge and the delight of my life, to try to figure out how to make a scalable healthcare company in Medicaid that solves a massive social problem. And I'm very proud of the results that we've found just by committing to a population, following them where their needs are, and building a big company. So that's been my journey. It's been a wild one. I wouldn't trade it for the world, and I really encourage students to look at all the entrepreneurial resources available to you at Michigan. There's so many programs, there's so many organizations in the community that will help you at least get the experience using the tool set of entrepreneurship in your career journey, whatever you choose to do. It's been great to share with you. Thanks for listening.
Woo! Thank you. Thank you, Lisa. Yeah, grab a seat. Oh, our water bottle's already out here. Thank you, students. Appreciate it. Everybody, do me a favor. Close your eyes for a second. Everybody close your eyes. And by show of hands, raise your hand if you know somebody who's had substance abuse issues. Thank you very much. Appreciate it. Sense of what we're working with here. So, I don't even know where to start. There's so many places that I would love to talk to you about this, but I feel like 2017 is a year. This is a pivoting year. Talk to us a little bit about how you knew that the time to pivot was then, how you talked to your Series A investors and made them feel comfortable with the notion of the pivot that was pending when they were already kind of vested into a model that you had going, and what techniques you and Robin used to bring them some comfort with what might be ahead.
Yeah, so I think it's important to note that before 2017, WorkIt was not a clinical services organization. WorkIt was basically a SaaS platform for, that delivered courses in the form of a share a day and in the form of all things that could be delivered without any medical practitioners. And that's what we were first invested in. So that when we raised a seed round, a venture capitalist in technology is going to be like, yay, there's no cost of goods sold. There's no people costs associated with this business. It's the next Uber, let's go. Or not Uber, but that's a bad example, but like say it's the next whatever e-commerce widget that you have out there that you can scale infinitely without needing more and more people as you scale, right? So we raised on that kind of a premise, and then when we got in there to do the work, we realized that we needed people. We needed people because the care system was so broken that everybody was delivering this really sketchy abstinence-based care, but that's not what the science was saying. So in order to survive, we needed to find something, a gap area where people desperately needed WorkIt, and we needed to build for that. And what we found was that Medicaid member in rural populations had nothing. They had nothing. And so we convinced our board that in order to scale WorkIt, we would need to be a full-scale medical services intervention for those individuals to replace the standard of care. And that we weren't going to be able to do it in big cities or even medium cities like Ann Arbor because people either had a research university or a trusted federally qualified health center. And not to say that those individuals were solving the problem, because as we can see from their longitudinal clinical trial, they have not. But we knew that we could build and we could find individuals that would part with money, MCOs, in order to deliver this care. And in order to survive as a startup, you have to have a business model. And so the board supported us because they saw it as differentiation, but they were quite nervous because they saw it as a low margin business. And it was a low margin. It was like a no margin business. And yeah, they trusted us. I think we surrounded ourselves with board members who believed in Robin and I as a duo, who believed that like together we had complementary strengths that were different enough that we were gonna figure it out. And that's what's important in funding early stage founders. It's like you have to believe whatever these two don't know, they're gonna find the other people that do know, and they're gonna be able to amass resources around themselves to take this to a feasible place.
Taking that back a second, the idea of, so when she's talking about board members, are we talking about folks who probably invested in you too, VCs that took board seats?
Yes.
Okay. So when we're talking about them, they had to believe you're passionate, they had to believe you're capable of finding the ability to work around the problem, find the solution, et cetera. What techniques did you understand as you went through these 300 plus pitches that looking back, you're like, wow, I wish someone would have told me I really could be doing X, or I should be doing XYZ when pitching?
Yeah, I mean, I think at the time, I raised in sort of the heyday of venture capital, which you are not in right now. And at that time, there was a lot of differences in different types of, I don't know, I call it the person. I've talked to you about this before. Like Chicago VC has a personality, New York VC has a personality, San Francisco VC has a personality. And you almost needed to have a different pitch deck for each of those marketplaces. And so what I learned was to tailor the way I presented the value proposition to who I was talking to. So if you're in San Francisco for instance, and you pitch and you come there with like these crazy financial projections that a business school student made for you that are like gap accounting the next 5 years, they're totally fictional, right? They won't fund you. If, they'll be like, this person's not a visionary. What is this person thinking? If they can make a model like this, it's not disruptive enough. This isn't gonna change the world. If you go to New York without that spreadsheet, they're not gonna fund you. So really, like, you have to know your audience, and you have to know exactly what they're worried about, which is, 99.5% of the time making money. So they're really going to be worried about margin, about your potential for top line, about your business efficiencies, and you have to really understand business fundamentals. And it took me a long time to figure that out.
In understanding business fundamentals, in coupling with the intentional design of WorkIt that you and Robin have done since its founding, you also went forward and made it a B Corp.
Yeah.
And that is not something in all the startups that I come across that is very common at all, let alone pitching to a VC about something that's a B Corp. Why did you decide to make it a B Corp? And then furthermore, how did that present in those fundraising conversations? And just for a sense of our audience, raise your hand if you know what a B Corp is already. Okay, so we can probably define that too, and I'll allow that.
Yeah, so when I studied at Michigan in the School of Information Science, my mentor was Dan Atkins, who's also a professor in EHour here. And he, as part of a project I did for him, I talked to like 50, 60, maybe 70 of smart people that he knew to try to help the School of Information think through of like ways to innovate their community informatics program, which was their social impact technology program at the time. And a lot of the people I talked to were microfinance innovators, were people that had built the B Corps movement. So I believed that this triple bottom line thing was really revolutionary. Like I had worked in trying to scale technology startups in nonprofit settings in ed tech, and it just was crazy. You just ended up getting a random grant from different things, but you could never scale. And so with a B Corps, you actually, if you do it right, you have your business bottom line, like your business model, you have your social impact metrics that you're responsible for to an ESG group. So now this is a whole category of investing, ESG investing. But when we started WorkIt, it was not. It was like, it
Pretty
wasn't
at
a
being
thing.
cool.
We were like ahead of the B Corps curve, I think. And now people are into it. But I think I just wanted to do it because I thought that was how we were going to solve a social problem. You can't solve a social problem without a business model that can scale itself without being dependent on somebody. And that B Corps let us do that. But I don't think it was appealing to anyone that we were pitching to at all. If anything, I think it detracted from our viability. And they were like, there's a lot of head patting. Like, this is such a sweet project you're working on. Like, what a great, bake sale you two are putting together. Atta girl, and we proved them wrong.
I'd say. In thinking about those fundraising pitches, I'm envisioning you and Robin as co-CEOs going into a meeting, having people not understand why there's a co-CEO model. But then, of course, on the back end, the complementary experiences that you two have had and her design background, being able to be brought in on such an early level and founding the company has, of course, led to an incredible amount of downstream success. Recently, given an award for Best Design in Class at a San Francisco competition that I read about. Talk to the students a little bit about how that intentional design mindset from the onset has both informed, built your employee culture, as well as challenged it. What does that look like as you've grown?
I mean, I think it's hard. Like, we recently actually had a design review by Robin's, my co-founder's husband, still does IDEO work. He did like an IDEO review of the inside of the app right now, and it was like devastating because it's become so much like an EMR. Like, you go in there and there's like all these checklists and video appointments, and it's just boring compared to like early WorkIt. So you lose some of it as you scale, and you have to keep building it back in and recognizing that you have more and more partners. But I think at core, what we held close to our vest was like, we knew that care had to be on demand because we had the problem. So we knew that, I think the human-centered understanding that somebody who's waiting to do a drug test, who wants to do heroin, right, isn't going to wait 10 minutes, right? So if drug testing doesn't work within 10 minutes, that person is going to leave. Like, that fundamental understanding made us design a better product even at this stage. So like, even recently we made a drug testing bot that lets people drug test in the middle of the night if they want. And those are simple things, like, technologically, it's not like your sexy machine learning project, but like for the patient, it's everything, right? It's like whether I'm gonna stay or go. If I'm like annoyed, I'm trying to call somebody, gotta wait till somebody pops into the drug testing room and pee while they're there, like, that sucks, right? If I can do it with a bot, that's like a better science way to do it, and it's a better human way to do it. And I think we stayed true to that, like our own ethnographic experiences, and review what every team is doing based on what it felt to be like in early recovery, and that has helped us keep that in the culture throughout. But if we didn't have enough patients as designers in the team to do that, it would very quickly become like a really, epic or something, like some weird environment where you're like, what is in here? Every time I go to a doctor's appointment, some nurse is practically crying about it. It can get really ugly in healthcare technology design very quickly, because there's so many data points. It's so complex.
And money's so tied in.
Yeah.
Yeah. In thinking about that test and iterate design process that you've gone through and you've had built into the culture, of course, y'all were the first ones to come out and be the pioneering model for digital addiction recovery. But fast followers always win in the long run.
Yeah.
How do you ensure that WorkIt is still capturing the market and that you're not out-competed and you don't become the victim of your own success?
I mean, as a social impact company, you're like, well, I hope there are copycats, because there's like now more people have died from this than have died from COVID in the United States. You know, part of me is like, screw it. If like, catch us if you can, and if it makes the whole field better, it's worth it, right? You know, selfishly, you want to stay differentiated, and I think the way that we've differentiated at WorkIt has been through data and design. And so as we get smarter at just having like thousands and thousands of people in the product, we have way better potential to create moats around data. And I think that the fact that we have these long-term, you know, cohorts of measurement-based care that have been with us for years now is, I think science and data are the differentiating factors in startups at the end of the day. It might not win in the short term. You can always have competitors out there, you know, pretending they have as many contracts as you do, or optically, you know, scooping your team or whatever it is. But at the end of the day, if they don't have a better care model that's actually delivering better outcomes, then the market will catch up with them, because the healthcare plans they're contracted with will break the contract when they realize they can't actually find the people or they can't treat the people effectively. So it's a long game you play when you invest in science, but I think it's worth it. And WorkIt has recently built a human-centered design team called Oracle and a team called Labs, both that are really focused on continuing to differentiate around data and human-centered design as we scale.
Catch us if you can. That'll be the line that I come away with and remember out of this. All right, no segue for this, but you're an Ann Arbor-based company. You didn't just pick up, go out to SF, go to NYC, go to Boston, go wherever you wanted to. You stayed here. Why?
Yeah, so a couple things. I mean,
to be clear, I don't say that in a negative connotation at all.
Yeah.
It's not the usual. So.
It's not the usual. So one, I'm like, I love Michigan. I always have. I was raised here. Like when I went to the Bay Area, I thought I'd live in San Francisco for the rest of my life. As I began to see mounting problems just across the United States, just in terms of the difference in what was available to me, even as someone in recovery in San Francisco versus in Ann Arbor versus in Detroit. U of M has, no, don't get me wrong, I had incredible care from being close to U of M, but my friends in Detroit did not. And I think as I aged and began to see that how much change was happening with climate, with social changes demographically, with young people not living and working in the Midwest, I became very passionate about getting back. Because a lot of people, there's a bigger problem here. Like more people die from opioids here than they do in San Francisco, because there's always been harm reduction services in SF. I think that was part of it. And then part of it is also like building in the part of the world that built you. So I have a connection here, like Michigan connections, experiences I had at this college, like shaped who I am, and I want to give back to that. And I also wanted to see this coastal mentality go away. I also thought it was extremely harmful the way people treated my Michigan accent in SF and the way they described my hometown as a flyover state. Like I have this sort of rebel spirit where I'm like, oh really? Like all the smartest engineers I know went to Michigan, and and I think that there was a fighting spirit there where I was like, this should be like the next big tech center because of climate change and because there's so much engineering and business talent and social science power on this campus. And so I think I had a big kind of belief that we needed to democratize economic development and have better access to startups in other economies, because there was so much centralization of wealth in just really limited parts of the country that might fall into the ocean. That's my big.
Well, thanks for living out your values and sticking here. It's impressive what you've been able to do. All right, quick lightning round before we turn out to some student questions here. The next big thing in telemedicine is what? It's the short answer.
Well, I guess the thing that I'm most excited about is and this sounds really dehumanizing, and I really, I run a company with hundreds of providers, is like the roboticization potential of care. There are a lot of people in healthcare providers that are doing really meaningless tasks like drug testing, like note-taking arduously that's leading to burnout. There is a lot of ways in which technology can enhance people doing the optimal thing in healthcare, the thing that's at the top of their training that really pushes these diseases forward. And right now, people have to do a lot of menial tasks. And I think that's holding back care in this country. So I'm excited to have engineering do the lift there and make people's lives easier on both sides of the equation, both the patients to make their experience seamless and as easy as Amazon to get in and out and get your coverage, and also for the providers who are really burnt out from this pandemic and everything that we've gone through to have like less of a, really sad manual note-taking. Like it's like moving to, in education, like we've moved beyond the blue book to like LMSs and things like that. We need more advancement in what average providers do day to day, not providers at the top institutions who have already had digital systems, but like the people in rural parts of the country.
Unleashing the potential of human creativity in healthcare. Next lightning round, give me the quick answer on this one. If you had a magic wand tomorrow, you would change this about what governs telehealth. One aspect that you would change.
I am a person who thinks we have a very corrupt healthcare system. We won't go too much into detail, but I think that the power of treating the Medicaid population with the same quality of care that you provide to commercial members is something that's devastating to me. Like realizing over the course of building this company how our systems, our structures are all optimized towards people that are struggling getting the shittiest care, I think is probably the horizon that I see, where I see the most innovative founders I know are working in like health tech for Medicaid, but they're wild and crazy, right? Like you're never gonna raise a massive venture capital around doing that, but that's where the need is, and that's where the social change is. So that's what I'm excited about.
Outstanding. And give me the one sentence answer on this one, the one skill set that if you're studying an entrepreneurship course, program, interest at U of M as a student right now, wow, you really should be learning blank. Brush up on blank. What would it be?
I mean, design. I gotta say this, like when I went to the School of Information, it was still transforming from being just a library science school to being a human-computer interaction school, but like the work I did there to study contextual inquiry and look at actual, archetypes of a person, a stakeholder going through an experience has been a huge differentiator in my career. A lot of people even say today, well, I'm in healthcare informatics. And I'm like, what do you mean by that? And they're like, well, I've been working in a 10 hospital system EMR for 5 years. And I'm like, doing what? And they're like, working on features in the EMR. I'm like, that's not healthcare informatics. Like healthcare informatics is actually understanding user behavior. And so any classes you can take on user behavior, human factors, really understanding patients, stakeholders, I think are hugely impactful on your career.
Truly knowing your client in that way.
Yes.
Outstanding. Okay, students, your turn. We've got mics that are going to be running up and down here. I can't see too far into the audience, so raise your hand. Sebastian, there's a guy right there. Looks like in green. Go ahead and speak into the mic, too, so we can hear you.
Okay. Oh, can you hear me?
Yep.
Yeah? Okay, thank you so much for coming. It's really, really cool seeing the work that you're doing. So I'm a public health student, and I noticed that, in the public sector, there's a lot of resistance, a lot of challenges of trust with companies that are profitable that are in the medical space. What resistance, if any, have you faced during your journey with your company, and what have you done to mitigate that? And just in general, is the public sector more open to companies like yours? What skill sets should we do if, as future entrepreneurs, we want to operate in the space to be transparent and show that we're truly trying to promote good? Yeah,
that's a very timely question. I think that the digital health movement, has been the Napster in the room for quite some time. And I think that people that are in bricks and mortar, whether it's, will use whatever policy levers or protective statements they can say about how we're not a star-bellied sneak as possible. But that's like any form of change, right? Like anything that's changed in transportation where we've automated anything, there's that pushback from whatever has been working in the past. And so I think it's fraught, right? I think for us, we invest in science heavily because we really, WorkIt Health on average makes $325 for most of our patients. We just have a whole lot of them. So I think there's also a lot of misunderstandings about how much money people are actually making. And so I think it's a story that remains to be told, and someday I'll write a book about it because I think it's really interesting. But I think right now there's a lot of fear in public health around things like WorkIt, because there is a fear that healthcare professionals are going to be commoditized and their work and their specialty will be devalued. And so I think that existential fear is not actually a reality, but I think it's creating a lot of pushback. And there's a desire to get the technology out of it so we make sure the workers, the skilled professionals have the work. And I think that's just an education thing. I think that, digital health companies have a mandate to communicate and help people understand the way we augment care providers versus replace them, because I think that fear of being replaced is pretty real in a lot of segments of society right now.
Great question. Rashika, is somebody over by you there? There you go. Come down here. This gentleman in the front. Show of hands, students, how many of you plan on going into a healthcare-related field? Maybe, sort of, kind of? Okay.
Hi, my father is, well, first of all, I'm a graduate student studying mechanical engineering, specifically mechatronics, and my dad is a healthcare provider in the rural Upper Peninsula, and we always have this conversation about how much he hates medical robotics. And let's face it, he's an old dog. How do you teach an old dog new tricks?
Yeah, I think this is a huge challenge. I think you bring the providers to the design table, and that's what we've done at WorkIt. So we started really from this patients as designers lens, and we're like, we're pissed. You're killing our friends, providers. Like, it was a little bit hostile, right? It was like, this has to be better. All our friends are dead. And then we were humbled over time, and we're like, we need providers at the design table too. So I think what's changed, how we've changed that approach, is we've brought providers as designers into the mix and really engaged provider stakeholders in what do they think the future of their care as they, from their lens looks like. And that's challenging, but I think that we can all get there. We have to get there. Like with the opioid crisis, it's like we don't have a choice. Like people are just like, I think someone in Cook County Jail, like 3 people overdosed in a week in Cook County Jail and, in Pennsylvania, like it's getting to like a crazy level. And so I tend to just what I tend to do when I'm talking to providers is saying, like, this is an emergency. Think about this like the work I did with Katrina, or the work that we do when we're responding to a massive COVID outbreak. Like this is like all hands on deck, all tools out. Like we're losing a whole mass amount of people. And so I think that helps too, just to understand, why are you using it? Why is it so fast? It's because the suffering is so great. And we still need all of these stakeholders. Like we still need your dad. Like we still need all of these different stakeholders there. We just need more than that to survive the amount of social isolation and grief that people are experiencing right now.
Great question. I would love to sit here for another 2 hours and continue this conversation. I know the students would too, but that proverbial bell, it's ringing. That's it for this week. Thank you, everybody. Thank you, Lisa.